Okay, so moving on, I'd like to introduce River Jiang. River's an advanced echocardiography fellow currently at the University of California in San Francisco. He's also pursuing a Master of Information and Data Science at the University in Berkeley, and through the British Columbia Investigator Program, he's working on applications of machine learning and computer vision for cardiovascular disease phenotyping and prognostication. He completed his internal medicine and cardiology training at UBC and obtained his MD from McMaster. He's very kindly agreed to talk to us today about his research on deep learning augmented ECG analysis for the screening of genotype prediction of congenital long QT syndrome. So thank you, River, and please tell us all about your paper.
Thanks so much, everyone. And thank you for the kind invite to come and present to this group. Very interested to see what everyone thinks about this project because I think there's a lot of very interesting next steps. But here to talk about this paper that it published last year, looking at using AI methods, deep learning methods for screening and for genotype prediction of long QT syndrome. So I don't need to introduce, of course, long QT syndrome to this group, but I think as we all know, one of the diagnostic challenges of this disease is that about half of patients can have a concealed phenotype of long QT syndrome. So with either a normal or a borderline normal QT interval, and there's a lot of overlap as well in terms of the QT intervals for people with a pathogenic mutation and with the disease and a normal population without the disease. So we aim to develop a machine learning model that can one, detect long QT syndrome on baseline 12-lead ECGs, and even on for patients who have concealed phenotypes of the disease, and also as a secondary outcome to distinguish between the two most common genotypes, KCNQ1 and KCNH2. This project was, of course, only possible through the use of data contributed from all the collaborators in this amazing HiRO registry. We use data across the entire data set. Because this project was based out of UBC, we termed the UBC Hospital and BC Children's Hospital data set the internal data set. And then we utilized the rest of the data set with patients from Quebec Heart and Lung Institute, Montreal Heart, McGill, Stollerly, into the external data set. The internal data set was used for training and doing some initial internal validations of the deep learning model. And then the external data set was used purely for validation, external validation of the model that we ended up developing. First off, we split the patients out into the group with long QT syndrome and a control group. The way that we defined the long QT group was choosing patients who the probands and also affected relatives through family screening who were found to have a pathogenic or a likely pathogenic variant in one of these two genes, excluding homozygous or compound heterozygous variants, and those with variants in more than one gene identified. And then for the control group, we looked at to expand the scope of the control group. Essentially, we looked at not just patients who ended up testing negative for one of the pathogenic or likely pathogenic variants in one of these two long QT genes, but also looking at all first-degree relatives of patients who were referred to an IA clinic and were found to not have any phenotype for disease, or who underwent genetic testing and were found to be negative for disease-causing mutations. We did kind of two rounds of external validation. I'll just briefly mention this part where, as I mentioned, we had that first external validation cohort But we ended up expanding the external validation halfway through the study just by including more patients to help with the validation of the model that we ended up developing. So this was with collaboration with Dr. Stephanie Grandin and Dr. Rafik Tadros through Montreal Heart. And that was going through a larger set of consecutive patients who were referred to their cardiogenetics clinic for suspected long QT syndrome. We developed this model, a deep learning model. It was based on the ResNet V2 architecture, which is a type of convolutional neural network, which has performed very well in just normal image recognition tasks, performing really well on image recognition benchmarks like ImageNet. And so this is like a neural network architecture that's not usually used for medical tasks and usually used for more like if you, for example, recognize a picture of a dog or a picture of a cat. And then this is just slightly modified to take as input instead of a photograph to take the time voltage data from an ECG as input, which ends up being a very minor modification actually, because instead of the three channels of color, you just look at 8 channels of time voltage data. This is based on some empiric testing. So we did a grid search. So it just kind of searched across a bunch of different types of architectures and different types of hyperparameters that you can tune when you're training a neural network. And this ended up being the best architecture with the best hyperparameters for the performance on our internal validation set. This is a consort diagram showing the flow of all the patients involved in the study. So overall, we had 1,000 patients enrolled after excluding a small percentage of the patients for having incomplete or corrupt ECG data or excessive noise in the raw ECG data. We ended up with still close to 1,990 patients. And this was, as I mentioned, split between the internal data set and an external data set for validation. When we're looking at the baseline characteristics, about 60% were female. The mean age was about 42 years, and we had a really broad distribution across various ethnicities as well: East Asian, Indigenous, white, and other ethnicities. This table breaks down whether patients who had long QT syndrome were part of the control group. So in our population, the resting QT interval was not itself a reliable indicator for identifying long QT syndrome, with about 70% of ECGs from the long QT carriers having a normal or borderline normal QT interval, which is similar and in line with that 50% estimates from previous reports. But it is a bit higher, which reflects the higher pretest probability of the patients that were going through referrals specifically to a specialized IA clinic rather than just a broad general population. So we developed this model, and overall we found that our trained model performed very well for the task of detecting long QT syndrome. When we're looking at the area under the curve, we have a receiver operator characteristic of, or the NUC of the ROC curve is about 0.81. And that's better than using QTC alone, which only had an AUC or C statistic of about 0.74. And that's shown in the black here is the model that we developed, and the orange is using QT alone. And then when we looked at specifically the patients who had concealed long QT syndrome, our C statistic still was quite good. It was 0.78, and this is over the entire population. When we break it down into cohorts, internal, external cohorts, we see that the model performs very well on the external external as well as internal cohorts, and slightly less well on the Montreal Heart Institute external cohort, which was a more stringent validation cohort because it involved a higher risk cohort of patients where it was harder to differentiate long QT syndrome from controls, but still had an AUC of 0.78 for identifying long QT syndrome. For the separate task of differentiating between the two genotypes of long QT syndrome, we also see that the model performs quite well. AUC of 0.91 on the external validation cohort for distinguishing between long QTS type 1 and long QTS type 2. And then when we look at the subgroup analysis, there were very minimal numerical differences between the internal and external validation in terms of the AUC or the performance of the model when we're looking at age, male, female, ethnicity, or heart rate. And I won't go over this more detail, but we also looked at how looking at a per patient basis, averaging predictions over multiple ECGs, and that didn't have a significant numerical effect on the performance of the predictions from the model. We also looked at inpatient versus outpatient setting, which didn't have a numerical difference. We looked at looking at probands versus first degree relatives, and that also didn't have a significant numerical difference. And then we also looked at the performance of the model in comparison to the expert measured QT intervals. And the model performed significantly better. This is a bit of a busy slide, so I apologize for that. But for example, if you look at here, for all ECGs, this is the prediction from the model. We're looking at about 118 ECGs. The numbers are much smaller because these are specifically ones that were manually reviewed by a human. So the model's F1 score prediction was 0.83 versus only 0.22. So substantially better performance with a sensitivity of 90% versus 36%. And that's just going off of the expert measured QTC interval alone, which is about what we expect because as we described, there's a lot of patients who have normal or borderline normal QT intervals when you manually measure them, and even if the measurement is perfect. So in terms of our discussion, so we trained a model that is able to successfully detect long QT syndrome on 12 lead resting ECGs. The population had a lot of patients with concealed phenotype, and it's also able to distinguish between the two genotypes. We saw really good performance across the various demographic breakdowns. And our performance of the model was favorable when you're comparing it to manual expert measured QT intervals. We have the model released. It's on GitHub, so the weights of the model are open. And then we have this online tool as well. So I can just show that briefly. Maybe I'll just stop and then reshare my entire screen. 1 second. So we have this website, ECG Tools, heartsandrhythm.org. And then what you can do is, so this, you have to have the ECG in XML format. You can upload it onto the website. This ends up being a patient who has a borderline prolonged QT interval on her ECG. And genotype testing showed that she had a pathogenic variant in KCNH2. And then when you click analyze, get this fancy animation, but this is the output from the model. So the model prediction accurately in this case is that this patient has long QTS type 2. I'm going to go back to my slides. So um, I think I kind of mentioned these strengths already, so I won't belabor the point. There are some limitations, of course, with this particular study. It was a retrospective case control design of the study, and we're using relatively high-risk patients who were specifically referred to the IA clinics. Um, there was, as mentioned, the reduced discriminatory ability or model performance in the lower risk Montreal Heart cohort. And then we also developed this model specifically for long QTS types 1 and 2. The other subtypes were not included. There weren't that much examples of the data in the HiRO registry that we had access to adequately train and validate the model. Um, so with that, I'll wrap it up. Thank you so much again for inviting me to present this paper. I'm really interested to hear what everyone's thoughts are.
Outstanding. Thank you, River. Great presentation and just fantastic paper. I don't know whether I don't know. I feel over the kind of humbled by how well it performed against us. I think even against expert readers, the model just did so well. I think we kind of teach these systems. You build the systems, you train it, and then it gives us back something which we're obviously not seeing. So are we learning from the model? Is it teaching us something about what we're missing in these concealed cases? Are we looking in the wrong place? Have we, what's your kind of feel about that? How's the model predicting these concealed cases that we're missing?
That's a really good question, and it's interesting because it's something that obviously I think about as well with the AI research that I'm doing. A lot of the concern, especially early on, is that these deep learning models work remarkably well, but it's hard to really know exactly how they're working. This is something that's changing even day by day. In terms of the ECG stuff, it's still early on. Like medical AI research lags behind AI research in the other domains, especially in like programming, math, and engineering. Just because I mean it's like in domain for the expert like AI researchers that work in those fields. We've seen that these like chain of thought reasoning models can actually uh, break down exactly the way that they're thinking, and in a way that it actually helps a lot for like people who are more interested in like AI safety or understanding how the AI models work exactly, to understand like the exact breakdown of the thoughts and how these models sometimes get to a certain conclusion. Um, that's very fascinating to see. It'll be really interesting to see if something similar can be done with um, these different kinds of models that we're using. Like we're using kind of a CNN architecture in this particular paper. Since we worked on this paper and this project, transformer models have gotten much better in these kind of vision and tasks. And we didn't use this architecture, and because I mean, this is like in the last couple of months, it's been changing. And then there were other studies looking at developing kind of similar models to ours, like a CNN convolutional neural network kind of architecture. And there are explainability techniques that you can use to highlight specific parts of like the average QRS or average, sorry, heartbeat, and can draw a heat map about like where it highlights on the ECG. It provides like a little bit of limited insight, but it'll just draw a heat map on the QT, kind of more on the end of the T wave. And it's hard for a human to look at that and say, okay, that's something that I can change about how I read the ECG, because it's not that kind of heat map, at least right now, isn't super useful. But it'll be interesting to see where this space goes.
Can I comment briefly?
Oh, please.
So River, I presume you're talking about, is it something called GradCam?
Yes.
Yeah. Thanks. So if you look above my head on my screen, you'll see an ECG from somebody, from a 10-year-old boy I met as a fellow who had long QT, whose grandmother died a month after giving birth to his mother. This was the sort of formative moment where I got interested in this. And I remember those two boys, and they grew up while I practiced there and so on. And the ECG was quite striking and part of our original description of exercise and stuff. So it kind of stayed with me as a memento. But part of it in retrospect is if you looked at that ECG, if you measured it carefully, the QT is a little long. But if you look at the T wave, it's definitely abnormal shape. And the ECG that you showed in your presentation very nicely with the ECG tools, I think most people who are obsessed with these things would have looked at the shape of the QT interval and said it would even have predicted long QT2 because of that notching in the anterior precordial leads. Yeah. So the reason I comment about this is that's just, I think, the sort of simplest first step in being more than just interval management, which is why the experts weren't good, because they were returning a number as opposed to evaluating the ECG. And it might have been interesting to go through an exercise where you showed people, the physician interpreters, that ECG and say, do you think the QT is normal, borderline, or prolonged? Do you think the T-wave morphology is normal, borderline, or abnormal? And then do you think the patient has long QT, yes or no? And my guess is the physician performance would have improved, but still wouldn't have come close.
Yeah. Yeah, I think it's phenomenal. And I mean, I'm assuming that the ECGs you were feeding in from the patients, these weren't generated from an exercise stress test. These were all just baseline ECGs. Yeah. Okay. What do you do with the paranoia? Sorry, what do you do with the paranoia that you want to feed all those ECGs that you've read before and said, normal, reassured, just to see what the system says? Sorry, David.
I may have missed this, but you can answer Simon's question, of course. But I was kind of curious to know: do you have an idea of which ECGs the network kind of struggled with for example, does it have any issues with conduction abnormalities, ECGs with ST changes? Are there certain types of ECGs that we should not be putting in? We should expect that the algorithm that this will struggle with to reliably give as a prediction.
I think that's a phenomenal question, and something that we haven't looked at in the course of this particular study, but and it really does dovetail a lot with Dr. Hansom's question about whether to just fully go out and deploy a model like this, well, any sort of these kind of clinical AI models, like this especially. It's really early on. We have to, as you mentioned, Dr. Lee, look at all of the different kind of edge cases and determine, because there's no way that any of these models that we're developing is going to be perfect in all circumstances, just like a human diagnostician isn't going to be perfect in all circumstances. And understanding those limitations and also validating on a general population level, or on any population level that we're thinking about deploying any model, is key before actually going ahead and just throwing everything through it.
Yeah, that's fantastic. Thank you so much, River. Really, 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 really great.